Hello, everybody. It's a pleasure to present our data today at the virtual SLBP meeting. My current talk is entitled Latent Clinical Anatomical Dimensions of Schizophrenia. And I'm going to present some new data from a project in which we are investigating multiple clinical dimensions and widespread brain deformation in one multivariate model. So before I'm presenting our new data, let me briefly introduce the literature about brain deformations and symptoms in schizophrenia. So what we already know is that schizophrenia is related with widespread brain abnormalities in cortical and subcortical regions. And what other groups have been shown is that these global and its extensive structural changes are related to subtypes with negative symptoms, cognitive impairments, and can also be identified in biotypes based on sensory cognitive data in schizophrenia. At the same time, localized associations, so localized brain abnormalities, has been related to negative symptoms, in particular in the OFC. Localized volume changes in the hippocampus, ACC, and insula has been related to cognitive symptoms, and structural changes in the temporal cortex have been related to positive symptoms. So we see there's a widespread brain abnormalities in schizophrenia, and these brain changes are related to the heterogeneous clinical profile of these patients. So this is the other point I want to emphasize before coming to our new results, is that we all know that schizophrenia is a very heterogeneous disorder. And we have multiple symptoms, dimensions, including positive symptoms, negative symptoms, cognitive symptoms, and affective symptoms, with the two axes, manic symptoms and depressive symptoms. And what has been widely recognized is that these different clinical symptoms can be expressed very differently in different patients. So patient 8, for example, in the lower left of this figure, might have more positive symptoms and affective symptoms, including depression and mania. And another patient, for example, patient B, in the lower right of this slide, might express more negative symptoms, cognitive symptoms, and sometimes depression. So this is something what for clinicians is very obvious. It's our daily business that patients with schizophrenia present in our daily clinical work with very, very different symptoms. So in the project I want to present today, we asked the question, how do multiple clinical symptoms map onto widespread brain deformation? So instead of looking at one particular symptom dimension, like positive symptom, negative symptoms, or cognitive deficits, we wanted to ask, okay, so what is, if we look at the complex clinical profile of every patient and relate this to the complex and widespread brain deformation we have been observed previously. To do so, we used a multivariate analysis approach. We used partial least squares, and partial least squares works in the way that it relates two different sets or two different matrices of data, in our case neuroimaging data on the one side and clinical and demographic data on the other side, and tries to identify latent combined variables between these two sets of data. So in the first row, we see the brain deformation as a schematic in the voxels, the voxel deformations, and in the lower row, you see the three different symptom dimensions we have investigated in our study. it's positive symptoms, negative symptoms, and cognitive deficits. And these two sets of data are correlated with each other and subject to a singular value decomposition, and we extract latent clinical anatomical dimensions. So our PLS analysis revealed basically three significant latent variables. So latent associations between the clinical set of data and the neuroimaging data. And in my talk, I will focus on the first latent clinical variable because this is the one which was the most stable one and the one we replicated. I will show you in the next slide. So, and this first latent clinical anatomical variable was circumscribed or can be explained by cognitive symptoms and negative symptoms. This is what you see in figure B with the individual loadings of each of our variable. You see that you have a high loading in the cognitive variables and you have a high loading in the negative variables, and these clinical data mapped on a distinct brain deformation pattern with frontal regions, insular, parahippocampus, hippocampal, and cerebral regions being involved. So as I mentioned before, the reason why I focus only on this first latent variable is this first latent variable expressed most of the, or explained most of the variance in our data, in total almost 30%. And it's also showed, what you can see in figure D, also showed a high correlation between the clinical and the neuroimaging scores. This is something which is which we would expect because partial least squares tries to optimize the correlation between these two data sets, and to replicate or to investigate the stability of our findings, we try to replicate this first latent clinical variable in a out of sample replication. So we used a completely independent data set and projected our first latent clinical variable on the brain data of these completely independent data set, and we were able to explain 30% of the variance in brain changes in these independent data set based on our clinical anatomical variable from our, let's say, first analyses. In other words, the clinical scores, the clinical loadings from our first data set were able to predict almost 30% of brain changes in our independent replication data set. In the next step, we were interested in trying to identify if the brain deformation of this first latent clinical variable, if this is explained in, or if this can be explained by well-established networks, functional networks. So what we did is we were taking our brain map and looked whether our brain deformation map is strongly related to one of the well-established U networks. And we used spin permutation and testing for controlling for autocorrelation to identify the significant association between the brain deformation and the intrinsic networks. And we were able to identify that the default mode network and the visual network anchors these cognitive negative dimension brain deformation pattern we have observed in our partial least squares analyses. So in other words, the cognitive negative dimension we have observed in our patient is specifically related to default mode and visual network deformation. So finally, in the last step, we were interested in how these clinical data and the brain deformation are related to other variables, including socioeconomic status. And what we found is that both the clinical pattern and the brain pattern of this first latent variable is associated with socioeconomic status. And what is the interesting aspect here is that although both are correlated and associated with socioeconomic status, a mediation and the analysis revealed that the brain deformation, the neuroanatomical changes, mediates the effect from socioeconomic status to clinical expression. So I come to the end of this short presentation, and let me summarize briefly our findings. So in our current project, we use partial least squares to comprehensively map clinical, neuropsychological, and demographic data onto distributed structural deformation in a single multivariate model. The first latent clinical anatomical dimension reflect cognitive impairments, negative symptom severity, and brain abnormalities within the default mode and visual network, and was replicated in an independent sample. Interestingly, the brain deformation of this clinical anatomical dimension mediated the effect between socioeconomic status and clinical symptoms. We conclude that multivariate mapping of clinical, cognitive, and neuroimaging data opens new directions of dimensional stratification for diagnostic and treatment in schizophrenia. This method and this approach can be complement categorical subtyping of patients with schizophrenia and can help to make progress in developing better treatment. I come to the end of my talk, and I would like to thank you, my colleagues and the research team at Montreal, at the Neuro and the Douglas, and I thank you very much for your attention.